Welcome to the Air Medical Today podcast. My name is Edward Ero, and I am your host for episode 35 on January 27, 2021. This podcast is part of the Ero Podcast Network, podcasts that inform by focusing on both the news and the people behind the news. With each episode of Air Medical Today, we explore a specific area of the air medical industry and community through the use of interviews. You can find Air Medical Today on the web at airmedtoday.com and on Facebook, Twitter, and LinkedIn. The audio podcast is indexed on iTunes and the video version is on YouTube. For additional information about the guests on the podcast, I also provide background data on the Air Medical Today website. If you would like to become a sponsor and or leave feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. Today, I am interviewing Mr. Tom Allenstein, the president and CEO of MedFlight of Ohio and MedCare Ambulaance, headquartered in Columbus, Ohio. Before we get to the interview, I want to go over some feedback from previous episodes and provide some general updates. As I announced in the last episode, Air Medical Today is also a video podcast now too. A big thanks to Michael Christensen, the Executive Director of Air Transport of Sanford Health, for being the first interview using video. You did a great job, Mike. As always, you can listen to the podcast and now watch it on the new Air Medical Today YouTube channel. The link to the channel is on the Air Medical Today website. If you have not listened to the past podcasts, please take the time to do so. There is some really interesting information on how programs are reacting and adapting to the COVID-19 pandemic, as well as handling the stress that this has caused for frontline staff. In the last several podcasts, I have been interviewing the leaders of various air medical programs. While there are many similarities, there are also some big differences on how these programs are organized and operate. Please tune in to these informative podcasts. I would also like to thank the followers of Air Medical Today on Facebook, LinkedIn, and Twitter. To date, Air Medical Today has 20,600 likes or followers. Thank you. It is my pleasure to welcome Tom Allenstein, the president and CEO of MedFlight of Ohio and MedCare Ambulaance, on the podcast today. Tom has been in this role at MedFlight since 2015 and has served as the chief clinical officer and chief operating officer from 2004. In 2020, he also became the president and CEO of MedCare Ambulaance. Prior to MedFlight and MedCare, Tom worked as a transportation nurse manager at Mayo Medical Transport and as a transport nurse with Eastern Idaho Regional Medical Center. Well, Tom, welcome to the Air Medical Today podcast. It's really great to have you here. Thanks for taking the time.
Well, thanks for having me, Edward. It's been a long time since we've had a chance to talk like this.
Yeah, it's nice. I know when I do these, I always learn something new, and I know we've known each other for a long, long time. And from preparing for this, there's some things that I did not know about you. But let's first talk about. In all these, I'd like to, talk about the people, and we're going to talk about MedFlight of Ohio. But I wanted to talk about you too. You started your career as a nurse, but I noticed that you first majored in chemistry and biology before starting your associate degree. Was that a change in direction? Were you thinking of being?
Yeah. So I actually started out in pre-med.
Yep, I guessed that.
In the University of Northern Iowa,
yep.
Majoring in chemistry and biology. Kind of realized shortly thereafter that was going to be a lot more work than I probably really wanted to put into it. My ultimate goal was anesthesia. I always wanted to be in anesthesia, so I was going to be an anesthesiologist. But I have two sisters who were nurses. up in Rochester, Minnesota. And so I kind of steered course to go into nursing to hopefully get into nurse anesthetist school. So that's kind of where I veered off from pre-med and went into nursing.
I got you. Was besides your sisters, was there anybody else in your family that was in
No,
healthcare?
nope,
Yeah,
nope, just those two.
interesting. Um, and then you are from Iowa originally, then from
Yeah, so I'm
yeah,
from northern Iowa,
yeah.
almost on the border of Minnesota. So I don't have the accent, but lived in the cold weather. So I was used to it.
What town?
Charles City, Iowa. It's just
Oh,
outside of Mason City, Iowa,
yeah, yeah, sure.
where the music died.
Yeah, yes, yes. Um, from 84 to 87, I noticed that you worked out in Idaho at the Eastern Idaho Regional Medical Center in Idaho Falls. And you were, I think, a charge nurse in the ICU and the ER and the member of the aortic balloon pump resource team. But then you helped develop the Air Medical Transport program. Tell us about that experience.
Yeah, so it was really kind of interesting. When I graduated college from Rochester, Minnesota, there were no jobs in Rochester. There was a nursing strike going on in the Twin Cities.
Oh,
And so a lot of those nurses came down to Rochester to work while they were on strike up in the cities. And so, knowing I needed to get a job in a critical care unit to get into anesthesia school, um, just fate would have it, I saw an ad in the local paper for a position out in Idaho for ICU and ER. And I thought, well, why not? Nothing ventured, nothing gained. So I
yeah.
moved out to Idaho and started in their ICU and their ER with the whole intent to just get a few years in the experience and then come back and go into anesthesia school. While I was there, I got fortunate enough that we decided that we were going to start up a new flight program out there, flying into places like Jackson Hole, Wyoming, and Salt Lake City, and all of that. The program lasted about a year, and they pretty much shut it down. I think they didn't have real full administrative support at that time, and so they shut down. It was about the same time that my first child was born, so we decided to move back to Minnesota to be closer to home. But it is something that I look on fondly because the experience I got out there was just absolutely phenomenal. We had invasive cath lab that put in a lot of balloon pumps, and so you saw I was part of a balloon pump team. I was
Yeah.
on call for 7 days straight. Anytime a balloon pump would be put in, I had to go in and help do the insertion, help manage the patient for the first few hours. And for that, I got $1 an hour to be on call. And that's why even today, I know there's 168 hours in a week because that's how much money I made to be on call for the week.
So, but talk about the flight program. Is that program still in existence or?
So they closed down. I moved back in '87. We shut the program down right around that time. And then they started up again in 1990 as Air Idaho Rescue.
Okay.
They managed it for a number of years. I think Air Methods ended up buying the program. So Air Methods now operates it still in Idaho Falls and in several other places out there.
And so was it, you were just asked to be on that team or
Yeah.
you had volunteered or?
So there was about, I think there was 8, 9 of us that were more experienced. Now, when I say experienced, I only had about a year and a half of nursing experience when I got asked to do that. But I was a charge nurse in the ICU, in the ER, and everything else. So, I moved forward and said, yes, I'd like to do it. So we volunteered. We did a bunch of training. We went down to, at the time, LDS Hospital in Salt Lake City. Did some training with them. Where I first met Frank Thomas. He probably doesn't remember that,
Oh,
but it had a big impact on me
yeah.
back then. But yeah.
Well, it's always interesting to see where people first get into the air medical world. So you moved back to Rochester in '87 to become a staff charge nurse in the cardiac surgical ICU. Were you looking still to go into more of the anesthesia nurse anesthetist, or were you looking to work with the Mayo flight team?
So,
or both?
the bug got in me. The bug got in me once I started flying and seeing,
Yes.
this was way cooler than watching a person sleep. I thought, this is what I want to do. So when I moved back to Rochester, it was with the intent to get on the flight team. They didn't have any openings right away, so I had to buy some time. I joined staff at the surgical intensive care, cardiac surgical intensive care unit, which was another great experience because I took care of patients all the way from day-old babies up to 100-year-old people having redo valves and all of that. So the experience was phenomenal. They had some of the world-class surgeons that were doing stuff that, a lot of places never saw, and we were doing them several times a week. So really enjoyed it. And I think, it mirrored a lot of what I liked doing with the flight team, because these were sick patients. You were almost dealing with trauma types of events. When they started bleeding out, you were treating them like a trauma, and you dealt with cardiacs and neuro. You got the best of all worlds.
Yeah, that's fantastic. So then once you became part of the transport team, you became the transport nurse manager in '97 and served in that until 2004. Why did you step up to that role, and what were the duties and some of the highlights from that experience?
Yeah, so that was one of those things that the job came open, and it's always been kind of my own personal philosophy is, if you don't put yourself in for it, you have no reason to complain about who gets it. So I threw my name in the hat. I knew that there were others more experienced, more knowledgeable than me, and everything else, but I really felt like I could do something better with it. And so I threw my name in the hat, and, through the fortune, or maybe it's their misfortune, I don't know, but I was selected to lead that charge. And that was my start in truly a leadership role. And I never looked back. It's been a great career.
What were some of the highlights? What exactly did that position do? Were you...
So I was over the Mayo 1 Rochester team, which is a helicopter. We also had Mayo MedAir, which was fixed wing. So we managed that. Some of the highlights of my time there was that we started another base in Mankato, Minnesota. And so to get that base up and operating, figure out different things with that, because we actually incorporated residents into the staff and utilizing residents. Mayo was it was a nurse program. We incorporated nurse medics into the program on both the fixed wing, Mayo MedAir, and then when we opened up the Mankato base, we incorporated them out there, and that was a great asset to the team, and I think really changed the dynamics of that team and our abilities. And just, the team was absolutely phenomenal to work with. They were such highly skilled, highly motivated people that it was easy to serve them, because I'd worked alongside of them. I had the best of all worlds. I was doing management, but I could still hop on the vehicles and go with them every now and then and do some things that we were doing. We were single pilot IFR. We were flying, doing a bunch of different things with GPS approaches. We were one of the first programs to actually be involved in the GPS approach program. Back when Dan Norman and Steve Hickok were
Yeah.
And so we did a lot of stuff with that. That was very exciting.
You put a lot of those around the state. I know there was one into Abbott in the Twin Cities that was put in by Mayo.
We put a bunch of them in. I don't remember how many, but we invested a lot into that infrastructure.
Yeah, that's great. So I remember talking to Rod Crane, I think it was 2003 or 4, who had just started as the president and CEO of MedFlight of Ohio. And I remember him relating to me that it says one of the biggest mistakes he had made is not having the final decision in hiring for the chief clinical officer. He said he's never going to make that mistake again, leaving it up to a committee that, you have them advise, but that the CEO makes the final decision. You were an applicant, I believe, in that process, but, weren't originally chosen. Tell us what Rod did and how you became the chief clinical officer and then later chief operating officer.
Yeah, so that position actually came open as the chief operating officer. And I'll never forget, I came here and I interviewed, and I was in our big conference room, and we had a horseshoe shaped desk around the room, and there were 30 people lined up in that room. That was our leadership team back then. And everybody went around and got to ask a question. And then they got to the
So was this in Columbus?
This was in Columbus.
Yeah.
And then they went around again and asked the second question. So I was in there over 2 hours being drilled by these people and everything else. Now, mind you, I'm from Rochester, Minnesota, and I come to Columbus. It's January, and it's 60 degrees in January in Columbus. And it was probably minus 30 when I left Rochester. I brought my wife here, and it was one of those things that I wasn't really actively looking for a job. And yet, once I came and I talked to the people, I really fell in love with it. That was in January. In March or so, we had the Ames conference in Washington, D.C. that we used to do every year, the mid-year conference. And I saw Rod, and he came up to me and he said, I really like you, and I really would love to have you as part of the team, but the group picked somebody else. And I'm like, that's fine. I'm not going to, be upset about it. I really wasn't looking, but I'll try it. And it didn't work out. I went back home and I just told my wife, because I knew who they had selected. And I told my wife, don't unpack your bags yet. I'm just not sure that person's going to work out. I know the company, I know what they are looking for, and I knew that person, and I knew that probably wouldn't be a good fit. And sure enough, about end of July, early August of that year, I got a phone call from Rod, and he said, Tom, are you home? Is it possible? I'm in the Twin Cities. Could I come visit you? And I'm like, okay. And so I told my wife, I said, because I'd gotten wind that he had terminated the other gentleman.
Oh, you had? Okay.
And so I told my wife, I think he might be coming down to see if I'm still interested. And sure enough, all my kids are lined up. They know what's going on. And a couple of them didn't want to move and all of that. And he comes knocking on the door, and he's carrying a dozen chocolate roses.
Yeah.
And he hands them to my wife, and we sat down and we talked, and I pretty much accepted the offer. He did offer me the job, and I accepted the offer right there on the spot.
Yeah, it was a great story. I remember Rod telling me that, and I think a good lesson as a leader too, that you can't do everything by committee. So
that's right. There is, input, but sometimes the decision falls solely on you.
So was it chief clinical officer and
So
chief?
I was hired. So he changed the job position to chief clinical officer so that it had to be a nurse, and the other person wasn't a nurse. And
I see. Okay.
The other people that had applied weren't nurses, and so he wanted me to really oversee the clinical aspects of it, but also, the role was really the chief operating officer role as well. I oversaw all of the operations.
Yep. Excellent. So in 2015, you were named as the president and CEO after Rod retired. Was that a big transition for you, or were you already really ready given your experience as the COO?
Yeah, so it was kind of interesting. So Rod retired, and he retired fairly abruptly, the end of 2014. So I thought he was going to keep going all the way to July 1st, and he ended up deciding he was going to retire in December of 14. And so they named me interim. And while I was interim, they held a number of meetings, the board, they being the board, held a number of meetings with the partners here. We call our employees partners at MedFlight. And so you had a number of meetings with the partners here, because there was there were times where I wasn't the most popular person. We made some decisions, and Tom's job was, as second in command, to enforce those decisions
Yeah,
and make those
implement.
things happen.
Right.
And so I wasn't necessarily the most popular person, and there were several people kind of pushing against me and everything else, but there were also some quite a few that were in support of me going into that position, and they just didn't know me still, even though I'd been here for 10 years. They still didn't know really who I was, because it wasn't my program to run. Rod ran it his way, and I had my own thoughts of how I wanted to do it. So that year was pretty tense, and I was named interim initially, and then the interim tag was pulled off in about October of 2015. So
Yeah. I think I do remember that.
10 months later.
So, wow. And so, let's talk a little bit about MedFlight of Ohio now. Another Rod Crane story. I hope he is listening to this podcast. I think it was about 1995. I was at West Michigan Air Care, and I think had done one of the first mergers in the industry of two competing programs in Kalamazoo, Michigan. And he had contacted me about, the merger, what types of things he should be looking for. And I said, well, that's great. I need some help with CAMES accreditation. So we sort of traded off on that. But I remember that merger, and all mergers are difficult, and it was in Kalamazoo too. But tell us about the formation of MedFlight of Ohio, from, I think it was the Grant Medical Center and the Ohio State University SkyMed program. Talk about
Yeah.
that.
Um, there were two competing programs here in town. There's really essentially four big health systems here in town. There's Ohio Health, which Grant is a part of, Ohio State, Mount Carmel, and Nationwide Children's. And so Grant had their own program that they started in 1982. It was well established. I remember crossing paths with the people from Grant at AMTC conferences years ago. They did a lot of research, great program. SkyMed started their program about 5 years later in 1987. And there was a lot of media here locally about, the air wars and battling and racing to scenes to beat each other there. And so in about 1993, 94, Rod Crane and Cy Woodrum was actually asked to come in and look at consulting on how do we merge these two programs. We need to decrease healthcare costs. Where overhead is being duplicated. There's a lot of issues going on, and so Rod, coming from the Twin Cities, where he oversaw the Lifelink 3 consortium,
Right.
had a little bit of understanding and came and worked through that and pitched a proposal, to which in April of 1995. The two health systems, Grant and OSU, agreed, and they merged the program. And I've always told Rod that I have the greatest admiration for him, because while I came in and had to manage the company and all of that, it was well established already, and I have a series of leaders beneath me that help work with all of the different areas. He did this by himself.
Yes.
He really put this thing together by himself, and did such a phenomenal job. And really, if there's lessons learned on anything, it's really to pay attention to how important culture is whenever you merge programs, because we had two different cultures of people. You had the OSU people and you had the Grant people, and there was some cultural differences that even 10 years into the program, when I got here, there was some remnants of the two cultures that I dealt with. About a year into the program in '96, MedFlight bought into Riverside Hospital, which is part of Ohio Health now. Back then it wasn't, but they had a ground critical care division. And so Rod said, we can't just always fly patients. We need to have alternatives. And so he had the wisdom to foresight to be able to see we need to transport patients even when weather's bad or they don't need the expense of a helicopter. And so he bought the ground critical care division. And even then, there was some challenges because, you've got, flight nurses who say, I don't ever want to go on ground. I'm a flight nurse. And then you got the ground people.
Right.
And, it was truly a caste system. It was a difficult thing for him to work through.
Yeah.
And then
Yeah.
he had
It's
the organization, a year later, and just really built the company at that point.
Yeah, it is a lonely that when I was in Kalamazoo, it was basically me until I started hiring people. And you're right. And I think the other thing that's hard in that case and in Kalamazoo was the two organizations still exist.
Right.
It's not like they merged and you formed the flight program. So you still have that, and you still have the physicians and the clinical staff at each hospital saying, well, I remember them saying, well, it can't be as good as our program, and it wasn't.
And it was interesting because Grant was a level 1 trauma center. OSU was a level 1 trauma center. How are we going to take these scene patients? Where are we going to take them? We can't just take them to a level 1 trauma center. We got 2 of them. And so they actually built a program where our communication system on any of those undesignated scene types of calls alternate. We take one to Grant, we take one to OSU, one to Grant, one to OSU. And when I say undesignated, there are certain designated ones like children's are going to go to Nationwide Children's. Burns are going to go to OSU, those kinds of things.
Yeah, it's in Kalamazoo, it was more, we went strictly just by where the referral was made, wherever they referred. Do you know when the 2 original programs were formed?
So Grant Life Flight started in 1982, and OSU SkyMed started in 1987.
87, okay.
Fun fact that Grant and their program, they had a base that they started in a little town in southern Ohio called Wellston, Ohio. That was the very first out-based, to our knowledge, very first out-based helicopter.
Oh, interesting. Yeah.
All the other helicopter programs, we put them on tops of hospital roofs, right?
Yes, right.
They had the mentality to look at it and say, well, why are we where the patients are coming to? We need to be where the patients are.
That is
so we placed an aircraft in Wellston, Ohio.
That is a good fact. That I've learned something new. I didn't know that. How many consortium members are part of MedFlight of Ohio? And
so we're owned by two health systems, Ohio Health, which now has a whole bunch of hospitals and all of that they own, and then the Ohio State University Wexner Medical Center. So we have 2 consortium members. We have from each of those, we have 2 board members. So we have 2 board members from Ohio Health, 2 board members from OSU, and they're usually high-ranking individuals. Like from Ohio Health, we have a president of one of the hospitals. We also have a senior VP in finance. From an OSU side, we have a chief administrative officer from the health system, and then we have a controller who works for the university hospital. And the interesting part of that person and why they're on that board is that individual was my former chief financial officer. So he worked for MedFlight as a chief financial officer, left here, went to OSU as a controller, and then got put on the board. So it goes back to, one of the lessons learned is be careful of the butts you kick on the way up, because they may be the ones you have to kick back down.
Yeah.
So as soon as he got named to this position, and he's my current board chair, I asked him, John, did I treat you well when I was your boss? Because now you're mine. So just always remember, things go around and they come around. So
plus, he knows a lot about where to ask questions.
Yes,
from financial.
He knows all the skeletons inside the book.
Yeah. You have some different types of members too, right? Could you explain affiliate and partner?
So we went out and for a while there, I think it was late 2008 or somewhere in there. No, it was before that, 98, sorry, late 90s. Akron General, they came to us and said, could we be a part of this consortium? But the two owners said, well, we don't mind having somebody in there, but we don't want any equity to be divided up. So they had Akron General join as what we classified as a Class B member. So we had the two Class A, which were the equal owners, and then you had a Class B. That Class B got one board seat. It was non-voting, and they could be participating in the board and all of that. Later on in 2000s, Akron General got bought up by the Cleveland Clinic, who has their own transport program. So they ended the contract with us, took on with the Cleveland Clinic. But we also have a level of membership called an affiliate member. And so Kettering Medical Center over in the Dayton area is an affiliate member, for instance. They pay an annual dues. They get their name on the side of the vehicles. They actually help support one of the bases over in Western Ohio financially. We also have Adina as a health system. They are an affiliate member. They get their name on the side of a vehicle, as does Holzer Medical Center down in Southern Ohio. So we have an affiliate members, we have Class B, and we have Class A. Although right now we don't have any Class B members. That's the structure of our.
Yeah, interesting. Yeah, that's a nice way to include other hospitals too. Back to your board. Are you a board member?
So I'm not.
Okay.
I am staff. I attend all the board meetings and of course have to answer for everything, but we have 4 deciding members, and they are 2 from Ohio Health and 2 from OSU.
Okay. And then is your board involved in strategic planning? And if so, how often do you do strategic planning?
Our board members, every year we do an annual strategic planning session. We develop a strategic plan that goes basically 3 years, but we check it every year to make sure that we're on target. Like this last year, we had a lot of changes. So we've just revisited the strategic plan to see what alterations we want to make, because it's always been my feeling that strategic plan isn't something you write and then put up on a shelf. It's something that your operational plan has to be bought into all the time and constantly be looking at it. And things change. We have new competitors enter the market. Well, it changes kind of some of our strategic thoughts.
Absolutely.
Different government things that force things down on you. You got to change your strategic thoughts. And so we're constantly adapting and changing, and I think that's really, I think the key to a successful program is one that can really adapt and change through time.
Yeah, I'm, as you know, from strategic planning is one of my big areas that
I learned from you.
Yeah, well, from MTLI. Talk about your mission, vision, and values.
So, this is probably one of the things that, I'm most proud of here is as you look at a mission and who you are, our mission is to provide customer-focused medical transportation solutions. And I always break this down for our people, customer-focused. Well, what does that mean? Who is the customer? At the end of the day, who are we focused on and what are their needs? And this is where I bring my Mayo to me as well. One of the things that I learned very quickly at Mayo, everybody knows the golden rule, right? Do unto others as you would have others do unto you. But we live the platinum rule. And the platinum rule is do unto others as others wished done upon them. Because we would treat heads of state and kings and all of that. Well, I certainly am not going to treat the king of Jordan the same way that I would treat myself. So, and I think that's the way I look at it here as customer focused. We think that we know what they want, but do they? do they really want that? And so we need to be focused on what their needs are. And the other word in all of that in the mission is solutions. And I just mentioned, how we looked at our board structure as a solution. We've looked at all kinds of things. We had a county-run EMS that came to us in the late 90s and said, could you manage us? Well, we're an air medical company. What do we know about running an EMS? But we said, you know what, we'll give it a shot. We ran it for about 10 years. And in that 10 years, we lowered the levy that was required of the tax payers over there and increased their service and made it better. We had a company out of Indiana come to us and say, could you dispatch for us? And we're like, well, we're an Ohio-based company. What do we know about Indiana? But yeah, we'll do it and we'll go for it. And so we dispatched, and we've been dispatching for them ever since.
Wow.
Yeah, there's a gentleman here in Columbus that has a series of restaurants, and he has a mantra that he has with all of his restaurants, and that is, the answer is yes. Now, what's the question? And so that's been kind of our focus and our mission. Our vision is really to be the premier provider of medical transportation logistics through innovation and customer focus. And when I say premier, we know we're not the only one. There's a lot of great programs out there. We want to be the one that people think of, and that's who you would want your loved one transported by. We want to be that.
Yep.
And then finally, really pushing into our values. Our values are safety, integrity, excellence, accountability, and compassion. And as we look at, safety is the top. And I always tell people, safety is not a priority here. Safety is a value.
Yeah.
Priorities change, values don't.
Yeah,
and so
absolutely.
And I think our people really resonate with a lot of that. And I see so much going on. I mentioned before we took on ground critical care years ago, and we had this dichotomy of, I'm a flight nurse, don't put me in a ground ambulance and everything else. When I first came during bad weather, most of our teams would sit around and, well, can't fly, right? We had a few teams that would do stuff by ground. They'd hop in the back of an ambulance and go transport that patient. And we did about 20 of those a year when I first came. Last year, we did over 600, where we threw our team when they couldn't fly for either weather or maintenance, and they don't even question it anymore. They're just like, let's take care of the patient. Let's go. And
that's right.
they do marvelous stuff.
Yeah, I have some questions for you on your ground, because I know you've done a lot with that. But before we get to that, talk about your senior leadership team. What are the positions, and is MedFlight totally independent, or do you rely on any services from your consortium members?
No, so we're completely independent, 501c3.
Yep.
And so I have, and these people just joined as these chief officers last year. I have a chief financial officer and I have a chief operating officer. And then the next level is I have 5 vice presidents that oversee different areas: clinical operations, information services, and business development, risk management, our ground versus our air. And then I have about 10 directors and managers that oversee specific functions within the realm. And so, this team of about 17 has been scaled back from 30 when I first came. And so and the company has grown exponentially too, might I add.
Talk about that. What do you mean?
So last year, in March of last year, we were a partner on a ground-based ALS BLS system. We were a 60% owner in MedCare Ambulaance. We had a partner from Michigan that managed it, and they were the 40% owner. We bought them out last year in March, about 2 weeks before COVID hit. So we started, management of this ALS BLS ambulance, and didn't really increase a whole lot. I think we increased 3 leadership people out of that mixture. So it's been a great venture, and it's probably one of the things that, again, will be a highlight of my career in doing, and, recognizing that we need to move patients, regardless of whether they're ambulatory, wheelchair bound, all the way
Yeah.
to critical care, helicopter. And so we do about 60,000 transports via our ground, another 5,000 critical care transports. And we went from about 150 to 170 employees to now we're over 500 partners with both MedFlight and MedCare.
Yeah. So I'll skip down. On your ground, the critical care ground was out of the MedFlight program,
MedFlight
right?
still
And then
is,
the
yep.
other venture you talked about was ALS BLS, right?
Correct.
As the MedCare ambulance.
That's Medicare. Yep.
Yeah.
They do ALS, BLS, and then wheelchair.
And that so that was a separate joint venture until you just bought it out last year. And what was the reason? Why did you buy it out?
Well, I think we had, some, the company that we were working with, they were Michigan. That's where they were from. And they were looking to sell their total book of business. They have a number of joint ventures throughout the United States. They got some in Illinois and some in Michigan, some in Ohio. And they were looking at selling. And we didn't want to necessarily have our 40% share of MedCare bought up by another company. So we decided this is the time that we should buy into that 40% share and get full ownership. It's really here to serve my owners, being Ohio Health and OSU, the Adena Health System, and some of the other health systems around. But it was really Central Ohio focused, and so they wanted control of that. They, being my board, wanted control of that for their systems.
So was MedCare a separate 501c3 then?
It is, and now it's a wholly owned subsidiary of MedFlight, but it is a 501c3.
It's still a separate corporation. Yep. Is it the same board of directors?
So it is slightly different. We have two overlapping, one from OSU, one from Ohio Health that overlap, sit on both boards, and then they have separate members. So each board has 4 members. So there's 2 that overlap, 2 that don't on both.
I see. But again, from Grant and OSU, or Ohio Health and OSU.
Correct. That's correct.
Yep. So let me go back up. Does MedFlight operate with a break-even budget, or do you have some subsidy from your owners?
Yeah. So for the first number of years that we operated, what the billing back then was that MedFlight would bill the receiving hospitals for that patient transport. And then in 2000, we switched to third-party billing. So in 2000, when we went to third-party billing, there was a subsidy set up to help cover some of the shortfalls for the bad debt and self-pay that couldn't pay and all of that charity care. And so they set up a subsidy back then, and that subsidy remains today, although it's been cut 3 times just in the last 10 years. We've lowered the subsidy 3 times, but we do still get subsidized by our owners.
Okay. Is that primarily because of the ground, or is it
ground? Yeah, because reimbursement, it's such a necessary tool, but the reimbursement is so poor on ground. And the model that we have of having crews that are highly trained, highly qualified, standing around waiting for those calls, you just don't make it up. I get $200 for a Medicaid types of patient, and it doesn't cover the fuel that it takes to run.
Yeah, you just can't bill as much for that. It's a real dilemma, and I think it's something that needs to be rectified to recognize. I mean, there's specialty care, but it doesn't really give you much more than ALS. It really needs to be a critical care level.
And I look at the patients that these people are transporting. I mean, they are on Hellas, ECMOs, LVADs, 9 drips, you name it. They see it.
So on your ground side, having the ground component, does that get in the way? Does it create some competition with other ALS, BLS providers?
So We do have some competition on the ground side. Again, most of our business is really focused around my two owners, and then we have a contract with the Adena Health System.
Okay.
So we're the primary providers for those systems, and then we'll work with the other providers around to help, take up some of the slack that we can't cover and all of that. And we do that on both the air and the ground side. We try to turn over where we need to, just in the best interest of the patient.
What I was thinking is that, does it create some competition? I mean, where people are reluctant to refer to you for other things because you're competing on the ground side?
That's interesting. What we see, that competition factor is that, we've got two big health systems, primary health systems, that are looked at as competitors with other health systems. And so we do see, some of that come into play more than anything else is, well, you're owned by Ohio Health and OSU, and we don't like them necessarily. So we don't like using you. And so we get the best of all worlds. And that is that we're owned by two great health systems, and we get the worst of all worlds, and that is that we're owned by two great health systems.
I understand.
I think from a competitor state type of thing, we try to work very well with competitive entities. We do different partnerships. One of the things, and again, I'm really proud of, is in the late 2000s, we started a partnership down in Portsmouth, Ohio, with a competitor helicopter program called HealthNet out of West Virginia. And we set up a program down there where we shared it 50-50. To the point where we painted the helicopter,
yes.
one side to look like HealthNet, one side to look like MedFlight. As a matter of fact, the picture behind me is that aircraft.
Oh, is that the one? Yeah, I remember the presentation at AMTC on that program.
And we affectionately called that aircraft Sybil because she had a personality.
Yeah.
And HealthNet managed it, and we would have calls. Originally, we had calls about every week, just talking about the management of that base, and then we backed them down to about once a month. And during the 10, 15 years that we operated, great relationship. And I've known Clinton Burley, who's a good friend of mine. I've known him for years, long before I came here. It's been a great relationship. On the ground side, one of the things that we're doing right now is for our critical care program, we have some hybrid critical care things. So we have a base up in Bell Fountain, which is to the northwest of Columbus, and we use the local ALS/BLS ambulance. They're licensed as a critical care unit. We use their vehicle and their driver, and then we put our crew in the back of it.
Oh, interesting.
Billing and all of that. And
excellent.
Darren Robinaugh, who owns that ambulance, it's been just absolutely phenomenal relationship, and I think it's a win-win for both of us.
Yes.
It's the community support and the buy-in for the community to provide it, and we're able to do what we need to do. And so, I believe, Rod, that was one of the things that Rod really pushed on, is this whole competitive issue, and he used the term coopetition.
Yeah.
We need to work cooperatively with our competitors.
Is he the one that coined that term? Or
I don't know. I think if you ask him, he will say he did. I'm not quite sure, but I'll give it to him.
Yeah. So that's interesting on the ground. I think that's fantastic. On why did the joint venture with HealthNet end? And I know from hearing it was actually HealthNet that actually operated the program, right? And that MedFlight put in the 50% of the operating cost of it.
Yep, we shared expenses on that 50-50. We shared revenues 50-50. The challenge was that the base was in Ohio, so a lot of the patients that we flew out of that base flew up to Ohio Health or OSU here in Columbus.
I see.
And a few of the patients would fly down into West Virginia, and their sponsoring hospital is like, well, I'm not getting the downstream revenue off of this, but we're sharing in the costs. And if you know anything about Ohio, Southern Ohio is very poor, not a lot of insurance insured people down there. So there's a lot of self-pay. We had a lot of bad debt, a lot of Medicaid types of things. And so it was a struggle a little bit financially. And I think one of Health Net's sponsoring hospitals kind of finally put, the kibosh on it and said, we just can't afford to keep, paying for this. So they backed out. We had some discussions. Air Methods was the provider down there of
Yep.
aviation services, and we talked to them, and they jumped right up and offered as a hybrid type of program where they would take the financial risk, and then MedFlight hired all of the partners that worked there. So we brought them into the MedFlight family and just kept the base running as a Air Methods hybrid.
Oh, so it is a hybrid now. It runs
Yep.
as a hybrid. That I did not know. Talk about your other bases. Where are all your bases?
So we go as far east as Morgan County, McConnellsville area in the southeast. We go north a little ways. My farthest bases are about 2 hours drive time from Columbus. But we're really central Ohio focused. And then because of the relationship with Kettering, my farthest west base is right on the Indiana border to serve them. But for the most part, we're central Ohio based. And we have now 9 helicopter bases. And we've got 4 critical care ground bases.
Do you own your aircraft, Tom?
So out of the 10 aircraft, we actually own 6 of them. 2 of them we direct lease from Milestone Aviation, and then the other 2 come from our air vendor, which is Metro Aviation. They lease us the other 2, so out of the 10. And
do you have all same aircraft? And what kind of aircraft?
They're all EC 130 B4s.
Mm-hmm.
And that includes the Air Methods program that they own that aircraft down at Portsmouth. And that is also an EC 130 B4. So that was one of the things I think really, it was a difficult decision, but it was a wise decision. So we made that decision again in late 2008. 2009, we decided to go. We were operating BK 117s. We had EC 135s. We had a couple different variants of the EC 135s. We had an A Star. And so, pilot couldn't jump from one aircraft to another. Crews would get into one aircraft and not know where anything is and everything else. So we made a conscious decision in 2009, 2010 to go to a unified fleet, almost like the airlines operating
Southwest, yeah.
One aircraft, one airframe. And now, you can't tell the difference between one aircraft and another. We started a standardization project about the same time, and I'll never forget one of my leaders at the time said, well, we'll standardize all these aircraft. We'll have that done in about 6 months. 6 years later, we were still working on making sure that all the aircraft were standardized and staying that way. And one of the crew members stepped up as kind of the lead in all of that and really sold why it's important, that muscle memory to know where everything is.
Absolutely.
In every vehicle, how many are in every vehicle. And they meet monthly to determine, is this the right amounts? And they used a principle called 290, 2 trips, 90% of the time. And that was to take out that, as a flight nurse myself, I'm always conscious of that one time where you had the busload of hemophiliac nuns with a seizure disorder and you didn't have enough of something, right?
Yeah.
So we wanted to take that out, saying no, 2 runs 90% of the time.
Yeah.
They've lived by that.
That's interesting. Yeah, it's done that at other programs. It's real important because if you're moving from one base to another, whether you're a pilot or a clinician, that everything's in the same place. On the ground vehicles, do you own those?
So we do own those.
Okay.
Purchase those, and that's one of the reasons why every year I'm looking at my capital budget, and even though we're a nonprofit, I tell people we have to make money at the end of the year because
Yes.
I've got to buy, and these vehicles cost $240,000 to replace. I got ventilators this year that, or another, damn near $500,000 worth of ventilators and IV pumps and all of that you've got to replace. So, you've got to be making money at the end of the year to be able to.
So how many ground units do you have?
So we
total?
have 4 in-service vehicles, but I have a total of 6.
Yeah, but on
So-
and then on the
So on the ALS BLS side, I have 70.
7, yeah, wow,
Yep.
that must keep you busy.
That does, and they are a very busy group. We do primary just interfacility transports, but we also do some 911 response. The way Ohio is set up, a lot of the 911 response is done by county-run EMS, public entity, EMS, cities, and all of that. Not so much in our area do the privates do the 911, but we do in a couple of areas do 911 primary response.
Yeah, okay. Do you do a lot of remounts with the ground?
So we'll do that periodically. We'll look and just change the chassis underneath the box. We'll do that. We're really looking at the model because, again, looking at the cost of the vehicles, we were using big international freight types of chassis, and
right.
mounting the boxes on there. And now we're looking at kind of downsizing, not too much, but to more of like a Dodge 5500 type of frame. And again, doing the boxes on top of that. And then we'll mount those.
Yeah, that adds a lot of other complication. I know when I was at Duke University, it's where I had a lot of experience with the ground side, with learning about all the remounting and how many miles you can put on them. You have an air operator for your helicopters. Who are you using, and they always been your air operator?
So when we first started the program, OSU was using PHI and Grant Life Flight was using OmniFlight. And so when they merged for the first couple of years, they still had 2 operators. And then they slowly got rid of PHI, and OmniFlight was our operator for a number of years until they finally shut down business. And in 2010, we switched to Metro Aviation as our operator. And I, really enjoyed working with Metro Aviation. They've been a great partner with us, working with us, and really support. I think their philosophies of safety and all of that really align with ours. So really been fortunate.
Yeah, of the operators too, they sort of stayed out of getting into the independent thing and serving hospital-based programs.
Contracts, that is correct.
Are they doing your interiors too?
So they did all of the interiors on the 130. That was the first time they had ever done a 130. So it was kind of
really?
Yeah, and talking to Milton Geltz at the time, he bought just the shell of a 130 to do all the pull testing that they needed to do. And so I saw the shell down there and I said, boy, that would be fun to make into a simulation type vehicle when you're done with it. Can I do that? And he's like, well, we've got a few other things that we want to do with it and all of that. So I didn't think anything of it. And then I went down to a customer conference a few years later, and we were standing there and they had a demonstration. And I walked outside of the hangars out there, and out in the field was this shell of the 130. And all the people that were at the customer conference were all lined up, and Milton gets into his speech and he talks about, what would happen if you got oxygen leak in your aircraft and you had a huge oxygen leak and then a spark went off, and all of a sudden he went bam, and the whole inside of that aircraft just erupted in flames and all of that. He exploded the inside of the aircraft. And I looked at him, I said, I wanted that shell and you blew it up.
Oh my God.
But then, he did that for a couple of demonstrations for the customers, and then the thing sat again. Well, he just called me about a month and a half ago and said, Tom, would you like this shell? I'm done with it now. And so he shipped it up to me. So I have a blown up shell sitting in my hand that I'm going to be working on to try and create a simulation vehicle out of.
Yeah, I think that's great. I see more programs doing that. I think Life Flight Network has developed one, and I think North Memorial Air Care has developed a simulator on site, and that's really nice to have. I know Aerovac
Just be for
has had one.
clinical. This will just be for clinical. It's not going to be for the aviation
Oh, I
side.
see.
They'll do that themselves. This will just be, for our clinical team to practice inside of a vehicle, more realistic environment. So we'll put our human patient simulator in there. We'll make them, load and unload balloon pumps and everything else, just like they would normally.
Yeah. Have you ever looked at, with the number of aircraft you have, of doing your own Part 135, or has that been something that?
We have been looking at that, and that's one of those things. While I'm very happy with Metro Aviation and very satisfied in our relationship with them, you've always got to be monitoring costs and what are the costs. Our reimbursements are not going up to compensate for the cost of aviation, and so we've been looking at, is it more cost effective to have our own 135? Is it more cost effective to have a partner on that and have somebody that has a certificate and knows what they're doing? When we had fixed wing, we had our own 135 in the fixed wing, and so I managed the individuals that managed our 135 certificate, and I learned enough back then that really, I'm a clinician. I'm not an aviation person, and you really need to have the expertise in
Yes.
aviation to
Yeah.
keep yourself safe. So, the key positions on a 135 certificate would be vital to make sure that you've got good people in those
Yeah.
roles.
Mandatory, really. Yeah.
Yeah, and if you had that, then having your own certificate might be a good thing. But we didn't have necessarily all the right people in those spots, and it made it very difficult to have our 135 certificate for fixed wing.
Well, talk about that fixed wing program. Why did you stop that?
So fixed wing has always been a challenge, and I did this at Mayo as well. And I think the challenge with fixed wing is that it's very cost conscious, because the patients, for the most part, are paying for that. Insurances don't compensate, don't pay for it, and so you've got social workers that are looking for the cheapest bid, and our model was not necessarily the cheapest bid, because again, we were here for an emergent response. We could do things in the fixed wing like balloon pumps and critical care types of patients. We operated a C90 and a B200, and so the health systems that we worked for are not huge draws outside of the region. At Mayo, of course, patients were coming all over the world to come to Mayo,
Yes.
but not necessarily for here in Central Ohio. Now, we had a partnership with the Cleveland Clinic for a while before they had their own transport system, and so we were doing a lot of fixed wing for them and all of that. But when we lost that partnership, it just didn't make sense.
Did you use the fixed wing to back up the rotor wing when they were down for weather? Or?
The weather was bad, we would use fixed wing for a little bit farther out than what
Yep.
we wanted to go in rotor wing. We would use the fixed wing, and that's why we had kind of an emergent response type of program where we had people in house.
Yeah. How many, or talk about your clinical staff, what capabilities that they have, the types of transports you do, and also maybe the differences. Am I correct to assume that your ground critical care and your air staff will go from one vehicle to another, or is it dedicated staff?
They're dedicated staff.
That is okay.
The ground people are dedicated to ground. The air people are dedicated to air, although the air people can do some transport and they pick up shifts, because a lot of them came from the ground side. So they'll go back and they'll work some of the ground shifts. Really, as I look at our ground critical care division, they're really the ICU. They do, like I said before, they'll do balloon pumps. We have a relationship with OSU in which we'll take perfusionists to do LVADs and ECMO types of transports. We do our own balloon pump transports on both air and ground. Right now, because of COVID, only our ground teams are doing the BiPAP patients, just because of the ability they can wear the half face mask and be a little more protected than we're set up in the air side. But most of the patients, it just depends on, if they require, a lot more drips or equipment, then we'll send the ground trucks. If they just need the speed and that high level of care, then we'll send the helicopter team. So most of them, when we do our regular education, they're intertwined. They work together on simulation, and they all have to be required to do the same things. We operate with a nurse medic team on both areas. And really, I'm blessed because I have some of the best people in the industry leading the different areas, and my director of education has just been absolutely phenomenal. I don't even want to get that out because I'm sure people will be trying to recruit her now. She really.
Should I cut that out of the?
Yeah, I'll cut that out. She's been just absolutely phenomenal, and really bringing our education to really much higher levels.
Yeah, I have some questions on your education because I noticed on your website. But how many total employees do you have with MedFlight and with MedCare?
So I have a little over 500 total employees. And of that, predominance is the clinical people. I've got probably, less than 50 administrative staff.
Yep. Great. I noticed that you have a MedFlight radio program. How did this get started? And are these podcasts? Is that what they are?
They are podcasts. And that came about in early 2014. At the time, one of our educators had this idea of doing some educational podcasts and interviewing.
I think I remember that. Yeah. Yeah.
And so he got this thing going, and we had a whole bunch of different, not only clinicians talking, but I think Rod Crane talked about his experience in the industry.
Yeah.
A day in the life of a flight nurse. All kinds of fun little podcasts that they've done, and we've had just a huge following. And at one time, I think we had listeners from pretty much all over the world, 13 different countries. We had a huge following over in Germany that was listening to our podcasts. And
that's great. So those are still going on.
They're still going today. As a matter of fact, I think they just are going to put one together here this week that they're interviewing our co-medical directors. So my medical director, Dr. Howie Werman, who has been the medical director since the inception, has been stepping away as he's tried to retire, and we keep pulling him back in. But he's being replaced by a couple of newer medical directors, and so they're going to do something, I think, later this week.
Oh, great. So is that indexed on iTunes? Can people get to that?
Yeah, I get it off of the Apple Podcast. That's where I listen to it.
Yeah. So
I think it is in other podcasts.
So for everybody listening, it's called MedFlight Radio.
MedFlight Radio.
Yep. You also have an online virtual education program. I think it's through even Eventbrite. Tell us about this. And can clinicians actually get continuing education credit by doing those?
We have partnered with different entities to do some of these virtual stuff. So we had a health system late last year that wanted to do it, and so we did a series of about 3 or 4 nights, and we had over 1,000 people attend these virtual sessions. I think the health systems then offer up the CEs and all of that. We have 2 events right now that we're working on. One that I think there's one tonight actually with Ohio Health in conjunction with Ohio Health, and then MedFlight. And we're doing 3 different nights of educational virtual sessions. I believe that Ohio Health will be offering CEs up for those. We also had an event that we've done 3 of. Now we've done 2 of them, and we still have 1 more to do with OSU. And that one I don't think has any CEs with it, because it's really about how to incorporate social media into your business and all that, and we're using the experts not only here at MedFlight, because we've got a great person that runs all of our social media, but also an expert over at OSU to talk about how that can be incorporated. It doesn't just have to be healthcare; it can be whatever your business model is.
Can anybody take advantage of that? I saw it on your website.
Yeah, I think if they search it, it should be out there. I'm not quite sure.
It's off your website. Yeah.
Yeah, I'm not that technical. I know that my computer works in the ON position and doesn't work in the OFF position.
So you have a membership program there, and I know that part of that's because some of your competitors do too. When was this developed, and what is covered? I noticed there's like an Advantage and then an Advantage Gold program. What are those
Yeah,
differences?
so we started a membership program years ago when one of our competitors came into the state, had a membership program, and Rod decided that, well, we should have one too, and ours would be a little bigger. And cover a little bit more in that we had our ALS BLS partner at the time agreed to doing it. So if anybody was transported by MedCare, they would be covered. If they were transported by our helicopter or ground critical care, they would be covered. And then there was another additional point that we worked with AirMed International out of Birmingham, Alabama, to offer up global, which the person would pay a little extra and then have a membership with AirMed International as well.
So if you were overseas or something,
yeah. So we're more than 200 miles away from Columbus, they would cover, the fixed wing piece of all of that. We really haven't pushed the membership program because we got into contract with most of the insurance companies. And so a lot of the people were covered that way. And then we have a very aggressive charity care policy that mirrors Ohio Health and OSU, to where we write off patients that just they have the financial need and can't pay and all of that. So really our membership program, outside of a few people, outside of our actual employees, the membership program is really only for our employees at this point, and they automatically enrolled and we pay for them.
So do you have your own government relations staff, both at the state and federal level? Do you have, or do you coordinate with your consortium members on that?
So I have a person on my staff who is a nurse and a lawyer. So she's my risk manager. She does all of our legal affairs. She does our corporate compliance. She does all of that. And then she also sits on the Ames Government Relations Committee. That's one of the things that she does. And she's very, very adept at all of that legalese that goes with government relations and all of that. But we really try to watch what's going on out there, and we'll voice our opinions where is necessary, either through our selves or through our association of Ohio Association of Critical Care Transport, OACCT, through Ames, or through the Ohio Ambulaance Association.
Anything you're doing in preparing for the balanced billing legislation that passed at the end of last year?
I'm trying to bury my head in the sand as much as I can, because I was really interested as this was moving forward, that it was one of those things that be careful what you wish for, right? I mean, there were a lot of different people pushing, this balance billing. It's not good to, charge these patients $65,000, put liens on their houses and everything else, which is why we went into contract and tried to get in contract with all of the insurance companies. And I couldn't figure out, about a year ago, I'm pushing, to re-up our contract, get our rates changed and all of that. And some of the insurance companies wouldn't even talk to me. They just, we're not interested in changing. This is the way it is. And so we're watching this legislation, and I truly didn't think that this thing would be passed. I really thought that there would be, enough pushback on it. And when it did pass, it was like, okay, we've got to really, be looking at what do we need to do now? Because again, I have some insurance companies that I've been in contract with that don't want to talk to me about, increasing the rates, and we're going to have to, cost of everything is going up. I can't keep at that rate. but they don't want to do that. So we're concerned about where this might end up and where this might lead us, because we know that Medicare rates do not cover our costs by
Right.
any means.
Or
But
or Medicaid. Yeah,
yeah,
it's
Medicaid's even worse. I
yeah,
mean, they're pennies on the dollar where Medicare is dimes on the dollar.
yeah, yeah. It's going to be interesting. A lot of negotiation work that has to be done before that's fully implemented in 2022. I think was the time. You were on the podcast early last year when COVID first hit. I checked in with a number of the programs. How has COVID impacted your operations? Or are you taking extra precautions? Has it caused some staffing shortages of just your own staff getting COVID?
Yeah. So yeah, it was interesting. We bought the ambulance company in the beginning of March, and then middle of March, COVID hit. And one of the first things that we ended up seeing is hospitals were getting prepared to be overrun, and so they wanted to set up a location here in Columbus at the convention center, similar to what they did in New York City, set up a secondary site. We helped set up the site down at the convention center to get another 1,000 beds. And then we had the transport program. We talked to a lot of the private ambulances. How would we move patients and everything else? Well, we never got to that point. And what we ended up seeing was a diminished number of transports because they weren't doing elective surgeries. They were, trying not to move patients that, didn't have to be moved. And so one of the hats that I wear is right now I'm the president of the Central Ohio Trauma Systems, which is kind of a group that's made up of a lot of the hospitals, EMS agencies, and all of that. And it's just really a forum for everybody to get together and collaborate and all of that. And so we took action as COTS in forming this group where every morning we were talking. And hospital A was telling how many COVID patients they had, how many beds they had available, how much staff they had out, and then hospital B and C and D.
Right.
And we developed this process where instead of moving those patients from the outlying hospitals into Central Ohio, we were moving them from one outlying hospital to another outlying hospital,
Yep.
lateral transfers to keep things balanced. And so that created a problem with the private ambulances, because now all of a sudden, instead of going 15 miles into this location, I'm going 35 miles to this other hospital to equal things out. And the cost of PPE on all of that, because you just never know. And so we were a fairly COVID off of major exposures to patients.
Could you repeat
Staff.
that? Could you repeat that? Because I lost you there for a second.
Yeah, so I think we've been very fortunate. I think since COVID hit, I think we've only had about 2 patients exposures to our crew, 2 major exposures to where we had to quarantine our crew and all of that. All of the exposures that our crew have been through personal exposure, and now they've been exposed at home, and so they're off
Yes.
duty and all of that.
Yeah.
But we really have been very fortunate not having a whole lot of impact that way. We've had at one point, I think we had out of the 350 to almost 400 people at MedCare, about 25 people off at one point. Otherwise, that was probably our peak. That was, I think, right after Thanksgiving. We saw a big bolt of people off. But
So
really,
did your number of transports go up? I know initially when I was checking in with programs, they saw transports go down,
they
but
dropped
now,
down significantly
yeah,
initially. It dropped down significantly because hospitals, again, weren't moving patients. And it seemed like patients weren't even going into the hospital. That's where sick people were. So they didn't want to go into the hospital, right? And then we saw our numbers kind of stabilize off. I don't know that our volumes ever went up, so to speak, but they got more to normal stages in the summer, in July, August. Somewhere around that time frame, we started seeing our numbers stabilize off, and we haven't seen a huge drop again since then. So But like I said, what we have noticed is that, and I shared this with my board just this week. Um, since June, we've seen an increase of about 5 loaded miles on our ground ambulance. Now that doesn't seem like a whole lot, but when you're doing 5,000 calls a month times that 5 miles,
It's a lot.
that's
Yeah.
12 extra hours to complete those trips
Yeah.
every day. So, it significantly impacts just that small detail.
With the when you were breaking up the Central Ohio Trauma System Board, so was that something that was formed because of COVID, or did it exist before that?
So Central Ohio Trauma Systems was formed years and years ago, before I even came into Columbus, and it was really set up to be a collaboration of all the hospitals talking about trauma and how
Okay.
we can be better at trauma care in Central Ohio and all of that. And then it kind of grew, and we added EMS agencies, Columbus Fire and some of the surrounding fire departments, to talk about what happens if hospital A is overrun with patients. Can we send patients to hospital B and really collaborate in moving patients around so that we don't have a situation where diversions are creating problems for patients? And so we really work together, and it's really a great group. All the hospitals in the primary area, plus all of Southeast Ohio, Southern Ohio, we all do all the disaster management oversight for
Excellent.
them. We did set up, because of COVID, we set up a lot of stuff through COTS. It's been a fabulous group. The people over there are really committed and wonderful at doing their job and protecting the citizens of Central, Southeastern,
And you're serving as president, right?
and I am serving as president right now.
Yeah.
Just another one of those things that you just got to be careful when they ask the question, that answer isn't always yes,
Yeah.
because then you end up in positions like
Well,
that.
it shows a lot about your leadership. I think that's great. Is MedFlight a member of AIMS and ACT? And
So
I know
we
you
are a
were
member of AIMS, but we're not a member of ACT.
okay.
We've been a member of AIMS since the beginning. Actually, my predecessor, Rod Crane, was an early adopter of AIMS back when it was Ash Beams. And
Yes.
he was the very first fixed wing program to join AIMS.
Right.
Back in the day. So.
Yeah. So, and you were, I know we served on the board together.
Yep.
You were a board member of AIMS, right?
Yeah, I was a board member for 97 to 2005, so almost 10 years I was on the board. I'd been vice president of the board. I've been secretary treasurer.
Yes.
Just pretty much every role on the board and all of that. And again, I go back to there's a saying, government is run by those who show up. We have no room to complain about what's going on if we're not going to be a voice to be heard. So
yeah. Got to be involved. Yeah.
Is if I want to fix the world, I got to participate in it.
You were also a regent with the Medical Transport Leadership Institute. When did you become a regent, and how long have you served now?
I went to school and got my CMTE in 2001, and then I joined as a regent in 2002. So I've been a regent since 2002.
Yeah, it's been great. I think that's a wonderful program, and I was very pleased to be part of that too. What classes do you teach?
So right now, I am teaching kind of an HR class on dealing with employees and all of that.
Yeah.
A little bit of HR law and all of that. I did teach some on culture. I taught some on employee engagement, and then I do a second-year class on advanced leadership. Really, as we go through there, I learn as much, if not more, than I think the students do there. And that second year class is really just a free dialogue with people to say, okay, give me a problem that you've had. How would you solve it? How have others solved it? And learn that, we all have the same problems. We all have the same individuals, just different faces, different names, and how we deal with them, may be different. And it's nice to learn from others so that you don't have to recreate it all the time.
Yeah, it's been, I think after I left, I came back for a graduate year, then came back and taught, I think, a couple of years after that because you needed some instructors. So it was great it's always a week that I'd look forward to. Was it a lot different this year with going virtual? Was it?
Yeah, so that was really difficult. And of course, some of the real benefit of MTLI is really the interactions that you have with the students
Yeah.
and they have with each other, and the networking is probably the biggest piece. So, we've struggled with that, trying to figure out, can we make MTLI more virtual? We did that as a grad school this last fall, and I think it was fairly successful. We had some great speakers, and it was really good from that aspect. But anybody that's attended MTLI, would know that, like, the second year group project, I think that would be really hard to try and do virtually. You get tasked with a very difficult case to try and solve in 3-4 days. How do you do that virtually versus in person, where you can sit there with
Yeah.
flip charts and really putting your heads together on solving it. So not quite sure. We're still looking at how we might be able to manage that in a virtual world, but I think
Yeah, it's not exactly that. I can see maybe, some of the graduate seminars, kind of what AMTC did this year, with going virtual, but still nice. It's such a great experience, and one that you don't forget. I mean, it's how successful that program has been, and thank you for all your work with that.
it's probably another one of those things that I put as a highlight of my career. That's
Yes,
been one
me too.
it's fun, even though it's a volunteer, you get paid nothing. And you think, well, I'm going to Wheeling, West Virginia. Where is Wheeling, West Virginia? And you remember the early
Yep.
days where you went there and you had to drive half a mile up the mountain to be able to get any kind of cell signal. I
Yes,
mean, you're
right.
completely disconnected.
Yeah,
But beautiful area. Ogle Bay has been a great partner in
yeah.
MPLI for many years.
I think it's been the magic of it. I think it was really Don Mancuso, who was the Ames executive director at the time, that really got us involved with that. You're also a site surveyor with the Commission on Accreditation of Medical Transport Systems.
I am a site surveyor for them. And I've been doing that since the early 2000s. And again, it's great because I get to see programs and see how they're doing things. And as you look at CAMES, you look at the standards that CAMES has set. And it's really about how you're meeting the standard and to learn through the years. I mean, when I first did it, everybody was going to the OR to get intubation experience. And human patient simulators really weren't out there. And we saw some programs early on doing cadavers, and we're thinking, well, that isn't, going to the OR. How can you be, doing it that way? But learning and seeing how
Yeah.
others meeting the standards has been great. And I've learned so much again from other programs and the great things that they're doing. And it drives, I think, my own company crazy because I always come back with ideas. Oh, this is cool. This is how they're doing it. And
Tom was just on another survey.
Exactly. That was exactly the response I would get.
Yeah, I think it's fantastic. I've always encouraged that because I think you do learn so much by going to other programs. That the time that you put in pays off in spades with what you learn. So, one thing I was looking, I just have a few more questions. That you were, I didn't realize this, and I might have either forgotten or maybe didn't know you at the time, but you had received the prestigious Marriott Carlson Award in 2002 while at Mayo. What was this for? And
Yeah, so the Marriott Carlson is something that I'm really proud of.
yeah,
It's excellence in kind of leadership and all of that. And um, you know, you never think you're worthy of receiving awards, and I truly didn't think I was. That same year, it was great, and I probably relish it even more. Is that Mayo received Program of the Year that year that I got there.
oh,
And
okay,
So, I don't know which one I was, more happy with, my own personal or the one for the team. And I think the program of the year meant a whole lot more to me than even
Yep.
the Marriott Carlson. But to see the people that have won the Marriott Carlson and to be considered in those ranks is just,
Oh yeah, that's I guess
um,
I either didn't know or forgotten that you had received that. That's congratulations. That is, I think, probably one of the most prestigious awards in our industry. So, and then speaking of program of the year, MedFlight received that in 2014, and
Yep.
um,
Yep. So that was kind of, it was great because I knew that Rod was looking at retiring, and he had really built this program and company into what it was. And so I was really pleased that we were able to get that award before he had retired, so that
yeah,
we got to see that.
that's great. Yeah, it's a nice award. I don't know, what they should do. I remember LifeLink, we got it in 2017. I remember a new employee says, "Well, what are you going to do this year?" And it's like, can you apply for multiple years, or is there one for the decade or something? But
How do you top that, right?
yeah. Um, so just a few personal questions. I know you and your wife Ann have been married 35 years, have a large family of 5 children. What are the ages of your children? And
My oldest is 33. He
wow,
actually lives in Seattle right now. I use him as an example a lot because he just graduated last year with his PhD in aerospace engineering. So he
wow,
is a bona fide rocket scientist. So whenever I try to present something to the staff and all of that, I tell them that I've run this through a rocket scientist, and I know that this isn't rocket science. So we'll do that. And then I've got another son who lives in Charlotte. And then I've got 3 daughters, and my youngest is now a junior at The Ohio State University. She's 20, and then I've got a 25-year-old daughter who is a nurse at OSU. And then
also you do have somebody that went
yeah,
into healthcare. Yeah,
third daughter, works in a group home. She's not a nurse or any of that, but she really takes care of people and is probably the most service oriented out of all of my kids,
yeah.
and does a fabulous job.
So you guys are empty nesters, or is there still someone
So
at
we
home?
are empty nesters.
Yeah. Wow.
Yeah. So my poor wife has to put up with me now, and but we do still have 2 dogs, so
Yeah.
that occupies our time. And
Yeah. That's great. I didn't realize your kids were that old, or I guess, just time goes by so quickly that you forget that, yeah, your kids grow up too. So, um, and so what do you do for fun? I know, I remember one year, I think I still have the picture of us golfing together at the Medevac Foundation golf outing, but are you still golfing? Is that,
yeah, periodically,
yeah,
between, trying to, manage it at work, and then some semblance of life at home, I'll get a few rounds of golf in. But probably my biggest, hobby is I still run. I
you do?
still,
Okay.
not as fast. You can clock me on a calendar these days, but it is still one of those passions of mine that I do. I'm signed up for a half marathon. We've got a team for MedFlight doing a
Oh,
half
great.
marathon this spring, and I've done over 20 marathons. I've
Wow.
got almost all of my kids to do either a half marathon or a full marathon with me. Just did a marathon in Columbus in 2019 with my middle daughter. That was her first marathon. So my
Oh,
son, my
excellent.
oldest son, is an ultra marathoner. So he does 100 milers. And I
Oh,
said,
God.
well, I will crew you, but I'm not going to run.
Yeah. 100 miles beyond. Yeah. I used to run all the time, but then I tore my medial meniscus from running. So that's when I took up bicycling,
Yeah.
because I didn't want to ruin my skiing. So, which I still do a lot of. So Tom, anything else that you'd like to say about MedFlight, or anything
No,
else that we might not have covered?
it's one of those things that, took a risk 16 years ago, took a risk in moving my family 700 miles from our native land of Minnesota to Ohio, not really knowing what I was going to get into and what was going to end up. But, it's been one of those things that, I can't remember who it was that made the statement, you score 0 times on all of those shots you never take, so I had to take a shot
Yeah.
and I have never looked back. MedFlight is such a phenomenal organization to work with. One of the things that drew me here was Rod really wanted to pitch an idea of servant leadership within the leadership team. And so I embarked down that realm of really learning about servant leadership, and it just fit, with my style. And I truly enjoy being a servant to these people
Yep.
that I work for out here. They are just absolutely phenomenal people. Every week I get to put together an article that just highlights all the great things that our people do. And I tell you, I get people submitting stuff all the time about just the different things that our partners do for each other, for their patients, all of that. And it's really a boost on a Friday after a long week to put this article together and just know that's why we're here, right?
Yeah.
I'm not directly taking care of these patients, but I'm enabling the people that do to do their job. And that's just such a wonderful feeling.
Yeah. So you must have convinced some of the ones when you were interim that were a little wary of your leadership that you are a true.
Some of them bought in after a year, and they saw it. They still were not bought in, right away. But I think over time, I think they've learned to accept that there are 2 Toms. There was one that was the vice principal enforcer Tom, and then there's the one who was trying to be more strategic and.
Yep. Sometimes both are needed. So. Well, Tom, thanks so much for taking the time today. Really enjoyed talking to you on the podcast today.
Thank you, Edward. Really appreciate it.
It's great having you. Thanks for listening to this episode of the Air Medical Today podcast. Please come back again and also subscribe to future shows by visiting the website at airmedtoday.com, iTunes, or on the Air Medical Today YouTube channel. Air Medical Today is also on Facebook, Twitter, and LinkedIn, and you can find the links on the website. Remember, if you would like to be a sponsor or provide feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. A special thanks to Stanley Reeves of Room Tunes for providing his song, Track 5, for use as the theme song for the podcast. You can follow Stan on Facebook at facebook.com/stanley.reeves.39. Take care and fly safe.